is some question about the technique, Erika, how to make the ultrasound window larger and the window with the moderator smaller. This is very simple. With the button on your machine, you can adjust your color box very, very easily. Once you know the button of the set, and you change the color box upon your you see how you will see your vein better. This is very, very, very easy. So with your application specialist, just one session with your application specialist, you will know, you will understand every button, what is the function of every button, the color, the gain, the velocity scale of the color, with the depths, with the beam mode, with the Doppler spectrum, with the velocity scale. Everything will be very easy with just one session with your application specialist of your machine. It's not a big deal, don't worry. Ultrasound, it's really an amazing modality. This is our eye. We see the patient from inside by the ultrasound. This is it's a beautiful modality, really, diagnostic beautiful modality. So now again with the please.
Yes, we have a male patient, and you have varicose veins here, but again, now what very should be, there are some varicose veins, but if you touch, you can, it's very clear. You can touch the greater saphenous vein there because there is really no fat. And you start here. So, okay, just have a look, but without complaints. So we are also on the floor, we will a little bit. I am showing you the classical investigation of the great saphenous vein running from the groin. We have artery, renal lymph node.
We have lymph node, yeah.
Oppression, perfect, everything's fine. I tilt a little bit in there.
Yeah.
There comes the junction.
Yep.
Great saphenous vein. We have tributaries of the junction. We have what we know Thüringer flow. And what did you see? Everybody of you are so trained. You say, the vein is very tiny. Coming back to Vasilas asking from minutes before.
This could be an accessory saphenous vein.
This is 3
anterior. Now there is no accessory. Anterior saphenous vein.
This is the anterior accessory saphenous vein is this one.
There is no accessory by the recent publication. Suad Dogenji and Professor Alberto Caggiati, they eliminate now the word accessory. It's anterior saphenous vein.
Okay.
All right.
Sorry, I didn't know that. It would take some years for me.
Very, very, very nice to see it. Thank you, Erika, because it's very important, very important.
So, and this one is a very healthy vein.
Yeah.
You ask, why would I touch it on the thigh when there is no reflux? Man ser on vilken man the motion of giving is so fine tiny that I lost it. So we go back there. Am I saying? So it looks like healthy, but we have not heard it. And since that doesn't work, so things shall have it. What's up with that?
It's an amazing maneuver. It has a name, this maneuver, Erika?
If it has a name, it is called dependency maneuver. What was the question? I didn't know. Was that the question?
The maneuver itself. So when you have a small vein,
yes,
and you don't have any reflux or standing position, then you ask your patient to lying down, to raise the leg, and repeat it again with the same level. This maneuver, I like it very much. It has a name, Mendoza maybe.
Oh, no, dependency maneuver. The Mendoza maneuver should be the top elevation. I published that in 2000, but I called it Woodstock maneuver. And this one, I published it only in German. And then the same month, it was published by Chris Latimer in English. So I had two stupid persons, the same idea. I always said it. We had at the same time, and it is in English, the name is dependency maneuver.
Hey, next day.
Yeah. And now, We go back on the great saphenous, which is so tiny and expands. Now there is no reflux. Because, believe me or not, it is healthy. This day is healthy. So we go down, 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 and look what happens. And then we go down on the great saphenous way, which is really, really expiring. You see here the fascia. Perfect. And what is this? What is this? Attention. What is this? You'll have a perforating vein. First, you have a tributary piercing the fascia saphenous, and then you have a perforating vein piercing that muscle. And we go and put color in it, and we see, oh, there is still from the dependency maneuver, we still have a flow there. The perforating vein, which is flowing, the tributary, flowing. And this is for the only one, intelligent ones between us, which is everybody. Am I being with that? Only with lesser. We see there is a flow, but what is alarming in this flow? This is the diastolic flow. This one is the diastolic flow. What happens with the direction? It is the diastolic flow with the correct direction. So what happened to this leg? And this is why I brought it to you. I do it, I do a longitudinal representation of the vein, which it's not as easy. Then I come from the box. This one is the tiny gray saphenous vein. I go down and try the tributary here, meaning the saphenous fascia, and the great saphenous vein on parallel. And I will do the color. Attention, color. You have in the abdomen an ascending flow in the great saphenous and a descending flow in the tributary. And why is this like this? Because here you have the conjunction of the, I have to go to cross section because it's easier in this case. Great saphenous vein, tributary. The tributary comes in the great saphenous vein at this level, and the perforator is sorry, and the tributary is meeting here. And between this point and this point, we have a diastolic reflux, but it is going upstairs. So it comes out here, it goes out here, and it goes right in through the perforating vein. Is it clear to everybody?
This is, you mean it's a closed circuit? It's superficial to the superficial?
Yes, we have here, here we have the, like, go back to the logical. We have the deep vein and the perforator coming also like grading vein, filling, refluxing. It's filling, it's a closed vein, but not as expected. Filling it downstairs, but it is filled, and this short segment has a diastolic flow, which is psychological, but goes up because the draining tributary is a little bit higher. I will paint it on the paper. Just a second. It was 5 years.
Perfect.
Not that one in regular. Yes, I have.
Erika, there is an interesting question from Professor Lowell Kabnik. About when you use the maneuver, Valsalva maneuver.
Nearly never.
So when you have your patient on standing position, do you ask him to do Valsalva, or you prefer when he is or she is lying down? Because repeated Valsalva maneuver can make the patient some dizziness or drowsy. What do you think?
Valsalva is depending on so many factors. The patient is do it in standing position, you can't repeat it, and so on. But as you have seen, I was able to show you all the refluxes and situations with combination of under compression of the heart, with toe elevation, and with the dependency maneuver. So I don't see the point in make Valsalva. And I'm so sorry for all the very, very good intentioned always books writing about Valsalva. Valsalva was relevant when you investigated veins in recumbent position.
I like that.
Don't have the gravity to help you in the reflux. But as long as you make the investigation in standing position, you don't need it. And sometimes, if I really investigate deep veins in the groin or iliac deep veins, I make a Valsalva when the patient was laying down. And I do it in the following way. I put my hand on the stomach and I say, press your belly against my hand. When they try to put on the belly, and so the reflux there or not. Because if you tell them to inhale, don't exhale, press, they either exhale or they do whatever they want. And so really, Valsalva is very seldom in my case. So now I want to paint here. Would you that's this? Do you see this painting here? I think you have to go near. So like this, yes. Yes, okay. So this is the deep vein in this patient. It goes upstairs, it's perfect. This is the terminal and preterminal region. Blood is going up. And you have the perforating vein bringing the blood outside. It cuts to the saphenous vein, and instead of going down as we are used to, it goes a little bit up. The reflux goes upstairs, and then it goes into the tributary. So you have a small dilated segment of the great saphenous vein, which is flowing up. And if we come to the question how to treat this patient, it would be enough to close here, because what she sees on the left, yes, it's this tributary. This vein has such good roundness, the great saphenous vein has so good roundness, that if the reflux coming from this vein, if you manage to make the great saphenous vein incompetent. Yes, we have the perforating vein, and we will close this one, the flow will go up here. So even we don't have to close the perforating vein because we have to circulate the blood vein upstairs. Yes, this is a very seldom situation. This is what I presented to you, that you have great saphenous vein dilated with diastolic flow, but in the correct direction. Is this clear, Fasila?
Can we put it much more highlighted, because we cannot see the diagram? I can say, instead the screen of the ultrasound, could we put the schematic diagram on this?
Can we put
because it's very interesting what you are saying now. It's very interesting, but we cannot see it clearly, the schematic diagram.
Can you please spell the screen for a while?
So the main image is the ultrasound screen. Huh? So if we can change it with the diagram, it will be great.
Maybe you can stop sharing screen and then put one YST as a parent.
Okay. Or perhaps we have another perforating vein of the lady or this. Okay, perfect. So here, now it is better, yes?
Now it's better, yeah, but it's not the single image. If you can make it larger.
I make it together, and so it will be better understandable.
Yep.
I read it again. So we have a deep vein going to the heart. Yes, a heart for anybody doing physiology. Okay? Then we have the junctions, saphenous membrane junction with the great saphenous vein. The blood flow in this vein is ortograde, antegrade. The blood flow in the junctions, antegrade. We have a tributary, which is refluxing. Yes? And we have to know where this reflux comes from, where the GSV is competent here. We expect the perforating vein, for example, here. This is a typical case. Going out here, going down here, going down here. But in this case, we have a seldom situation with the perforating veins below the tributary. So we have the reflux from the deep vein. We have a dilated great saphenous vein antegrade, and then the tributary. And the complete great saphenous vein has the antegrade flow. So it would be a pity to destroy it anyway. Interrupting this one here would have the clinical result that this vein will disappear. You may, after interruption, you may make a phlebectomy or whatever you want with this vein. And if you leave the perforating vein, you will have the situation that the flow coming out here will go upstairs and right into the vein again. So even if this is a...
It seems that some people, they cannot get the image till now. I have a lot of not able to get the image, or are only seeing the modified MOH screen.
Yeah, but if
The screen not visible.
in a view, if you cannot see the screen, change the view and it shows the venous screen. As the Zoom platform, you can change what kind of view. Is it the all speakers or the venous screen? If you are using one, you can just switch screen. If you are using the computer, then you can use to bend the screen that you want.
It's something smart in mind, reflective. Woman is actually putting the mouth cleaner.
So now,
Well, just
I will get it. It's very okay.
let now get answers.
محمود، هو ليه مش عارف ليه السكرين بتاعتك هي تبقى كبيرة؟
I must two mics on. Vasila, do you hear me?
Yes, I can hear you. Yeah.
I will something. We'll do something else. I will take a Word. This is a Word document. Please do not look at what is there. I will open an empty one, and I will paint what I painted there. Just have just a moment. This is the deep vein. Well, no, sorry, I could have made the arrow. Oh, sorry. So, you are seeing the wrong thing. Sorry, I will do it again. This one. Okay. We have the deep vein. Sorry, I'm not so good in painting.
No, perfect.
Yes, we have the
I can see.
vein.
Yeah, that's perfect. That's better. Yeah, thank you, Erika.
Now we have the anterograde flow in the great saphenous vein. We have the refluxing tributary, which is refluxing, really refluxing. Yes.
Yeah.
Then we have the perforating vein, which is also refluxing. Yes?
Yes.
And we have the strange, it is not very often situation that this segment of the great saphenous vein has a diastolic flow, but it is antegrade. So we have a reflux in this perforating vein. The reflux goes anterograde upstairs and then retrograde through the tributary. And he has just told me that he went to a clinic like nearby. They love to strip veins, even though the veins are healthy. And they have recommended him to make a stripping of the great saphenous vein from the ankle to the groin, because it brings far more money than making this interruption here. Because if you take out this connection, the flow from the deep vein may continue going outside here, but it will be anterograde, draining again to the deep vein, because obviously this great saphenous vein has so competent valves that the reflux from the deep vein was not able to revert the flow here. Normally we expect that we would have a reflux here, but this didn't happen. Yes, this reflux didn't happen in the leg. So he has a very, very healthy great saphenous vein overloaded by a perforating vein, giving this overflow to proximal tributary and then being again healthy. This is for me, very interesting situation. This is why I wanted to share it. But now the image has been clearly seen, yes?
Thank you, Erika. It's very interesting because this is our really daily life practice. But
yes.
I wish to ask you about the treatment in this case. What you would like to do for this patient if she has a tributary incontinence that comes from the perforated, the reflux comes from. Yes. What would be your treatment for such scenario?
As I pictured here, I'm not treating him because he has no complaints.
No complaints, so no treatment.
He has no problems. So he is coming to my office yearly since 4 years. The tributary is not getting longer. He has no edema. He has no discoloration. Why should I treat him? The only thing I know when I treat him is that he will have a recurrence by 50% of cases after 5 to 10 years. I have one more patient. Yes?
So you do diagnostic treatment in the same session. With your probe, she has no signs, no anything, no complaint. That's really great. Can I ask, she has on compression therapy?
Yes, on calf compression therapy. He is an asymptomatic C2 patient.
All right.
But if he was symptomatic, or if he asked me to treat him, I would start just like I pictured here. I would start disconnecting the tributary from the great saphenous vein. Even you can do it with a foam sclerotherapy, you can do it with a surgical disconnection, you can do phlebectomies, whatever you, but not touching the great saphenous vein, which is completely healthy. If the perforating, if the perforating,
I would say for the foam, sometimes we cannot really control where it will go. Sometimes in this scenario in particular, some of the foam can go easily, go to the JSB or to the perforator. What will be your tips and tricks here? Yeah.
This is why I wouldn't select foam sclerotherapy in the first point, but if you think of it, always when you make foam sclerotherapy of the great saphenous vein, you will have inflow of foam into the deep vein, and nobody bothers what will happen with the deep vein, because the foam sclerotherapy, as soon as it gets in touch with blood, it will be no effective. So I would expect the same here, but personally, I would prefer to do a surgical little incision here and disconnect, a flush disconnection of the tributary at the level of the great saphenous vein. And then I would wait what happens with this. And I can tell you by 27 years of experience, it will be still refluxing the perforating vein. The blood will go upstairs and drain to the deep vein, and nobody will bother with him, with the blood, excepting for eventually a new tributary will form. Yes, but closing tributaries is very difficult because you have to make a long scar. This tributary was tortuous. You can't go inside with a good probe. So I would just say he is asymptomatic. He needs no treatment. But I know this is not very monetary good. Yes, so all the people treating for monetary reasons would not share this opinion. I'm sorry for that. Now we go to the next.